Welcome to Your Practice, Your Money, the podcast where clinical success meets financial freedom. I'm your host, Dr. Dimitrios Kostopoulos, and in every episode, we bring you actionable insights to grow a thriving and profitable healthcare practice. Are you charging what you are worth? Are you attracting and keeping the right patients? And could perhaps diagnostic testing be your next major revenue stream? And is your practice truly set up to work for you, not the other way around? Well, if you are a physical therapist, a physician, a chiropractor, a podiatrist, or any type of healthcare entrepreneur, this show is your roadmap to next level success. So let's dive in. All right. Hello, everyone, and thank you for joining us one more time today. Dr. Dimitrios Kostopoulos, I'm the co-founder of Hands-On Diagnostics and also the director of the Hands-On Diagnostics residency program. I have with me today a pretty amazing guy. Not only he is a physical therapist of a very amazing practice in California, but also a HUDS member for several years now. And I would say he is one of the people who have achieved a multitude of things in the area of diagnostics because he is board certified in clinical electrophysiology. He's an ECS board certified and board certified in a state that has additional regulations for board certification. So, and I'll talk to you about this in a moment, but I want to welcome my very good friend, Skye Grayson, who will share this discussion today with us. And Skye, I mentioned that you are from California. You're practicing California and you're board certified, ECS board certified there. The state of California has an additional certification where you had to be certified first for the state of California and then through the ECS process, right?
Yes. Yes. So, yeah, you can have an ECS and not practice in California. So you have to take their board certification, which is kind of like taking the board all over again. So it was great. I got to do it twice in a couple of years. That was fun.
All right. First of all, let me ask you, when you decided to be involved and learn and put in your practice EMG, nerve conduction studies, and musculoskeletal ultrasound, why did you do that? And how has this affected your practice specifically?
Yeah, good question. I mean, I think there's multiple layers to that. I think for our clinic, we've decided to not do anything that doesn't bring value to the patient and value to the community and value to our team. So that's helped us make decisions. And so, a number of years ago, California, like New York, a pretty difficult environment, lots of practices, lots of competition. And so what's the differentiating narrative? And so for us, getting to see musculoskeletal ultrasound and EMGs as a differentiating factor to take something that's subjective, make it objective, and help us help our patients better and faster. I mean, if I just summarize it simply, that's probably been the patient narrative because we use that every day, right? So if you don't believe in what you're doing and if you don't think it's going to help your patients, then it'd be really hard to create a new program for our clinic. The second piece, I think for me as an owner, as a therapist, looking at Southern California not being the cheapest place to live, looking for an opportunity to create a higher value service that can afford higher wages in our neck of the woods. And so that was something that was huge for me, as I had been in the career for 20 years and I had played all the games, push volume, push, modalities, all those things. And for me, I didn't see how we could continue to keep up with the needs of our team. And then from just the clinic perspective, offering a diagnostic service has really put us kind of in an elite category of clinicians. I spent a lot of time on the sports fields. I didn't think it would really impact that area as much as it has, and yet they love to ask me questions, and again, only enhancing our reputation amongst both the physicians as well as the coaches and the patients and the normal people in our community. Because none of them really care what an ECS is as far as in the normal community, but the physicians and stuff, that carries more weight.
Something you brought up, the physicians aspect, and I would like you to elaborate a little bit more on how do you manage relationships with physicians and the diagnostic testing that you offer in your practice? Because I'm sure you have physicians who love the fact that you do diagnostic testing. You have some physicians who are indifferent. You have perhaps a couple of physicians who do not care in particular for you doing diagnostic testing. What are these relationships? How they are cultivated, and how do you go about managing them?
Yeah, I would say we have all three of those kinds of relationships. And what blows me away is I'll speak about the difficult ones. The ones that love you, love you. That's easy. The ones that don't. And I remember going into a local neurosurgeon's office with our ultrasound, and he kind of thought it was nothing. And then we did a quick ultrasound of his carpal tunnel, and he just thought, he's like, holy smokes, you can actually see the median nerve. He had no idea how good the images were. He must have been thinking ultrasound from many, many, many years ago. And then when we started talking about electrodiagnostics, he's like, oh, let me be clear. I will never send an EMG to a physical therapist. And I was like, whoa. Again, not trying to rock the boat, just it is what it is. Well, within a year, he was sending almost exclusively to us for EMG. And he was the single most important physician in getting us a contract with one of the larger managed care groups in this area, which I found almost comical. Like, here you are going from one extreme to the other. And I think honestly, it was the quality of the reports that speak for themselves, because although I think few physicians are maybe that bold to make a statement like that, they're probably thinking it, because you have some on the fence or not really engaging in the conversation, and maybe they're in a pinch and they send you one, and then all of a sudden you're seeing a lot more. And as we begin that part of the conversation with our referral sources, that's been a surprising thing. It seems like the quality of the work speaks for itself. I only know what I was taught through HODS. I only know that piece. And so the reports seem to hold up well. And I always ask for EMGs from if they get them somewhere else in the community. And it seems like we do a good job. Physical therapists work hard. We're grinders. And so again, we like to do the things that we're taught and like to do it well. And so I think that's really helped our reputation as it relates to those physicians. So
I am about to release, and this is going to be a pretty extensive white paper. It's called The Raising Standard, Competency of Physical Therapists, Residency Training in Clinical Electrophysiology Compared to Physician Pathways. The vast majority of these studies are physician-performed studies where they look at the education that physician programs perform. We compared that to our own, the HADS residency program. Just to give you an idea, specifically in the area of electrodiagnostics, we spend, each of you who is trained spends 2,000 hours in that area while neurology residency programs specifically on the area of EMG testing, they spend the maximum 320 hours. PM&R, about a third of what you spend. And in terms of cases, in order to sit for the exam, you do at least 300 plus graded reports, okay? And that is not the case for neurology residency programs or PMR residency programs. Of course, the residency, the hours of training is very significant, but we have also the Elaine Armantrout study where she looked at the compliance of physicians versus physical therapists who did reporting for carpal tunnel, ulnar neuropathy, and cervical radiculopathy, and how these reports that were reviewed were compliant with the generally accepted guidelines by AANEM, the American Academy of Neuromuscular and Electrodiagnostic Medicine. And the results, as you can see in front of you right now, are staggering, that physical therapists were in compliance significant higher levels than the physicians in terms of the detailing of their report and how they express their report findings and so on and so forth, and other parameters that I am going to discuss in detail when I release the white paper. But definitely I can say that the kind of quality of education, the competency that it achieved through education, and the final product that our graduates put out there is absolutely phenomenal. Let's talk a little bit about patients. What is the clinical value that you have seen with your patients in the practice?
For the physical therapy patients that come in-house, I guess you could say, from our own physical therapists, it's important to remember, like, they don't have all the training that I have and the others in the clinic that are going through it. So trying to help them understand that value. But the bottom line is you can rank the severity of some of these injuries or the location of these injuries with so much confidence with an EMG. And so when you're trying to rule out, is it coming from the neck or somewhere downstream, or the back or somewhere downstream, or a neuropathy, all those variables, to be able to speak confidently and objectively to that with an EMG is huge, because I think that gives the patient a sense of they know what they're doing, right? They know exactly what they're working on. And I think through the training we've done over the years, how do you treat a myelin injury? How do you treat an axon injury? And what do you do differently? And then getting the results that you would expect for that. It's really helped to direct our care in that way. The biggest surprise, I would say, is the power of a normal. I will really say that's been something I never really would have expected when you're doing an EMG for someone that's got pain and their nerves are healthy, and you can tell that to the therapist. Now they can treat what they see with confidence, whereas before they thought there was something crazy going on, and the patients really, it almost seems like a yoke comes off their shoulder. That was something I would have never anticipated, and really has been powerful in the day-to-day operations just for our clinical team.
Give me one or two specific examples about that, like of a patient being treated by a therapist who was not trained in diagnostics, and then how the patient getting either EMG and or MSK ultrasound, how that affected the change of treatment plan.
One of our therapists in-house had recommended an EMG, and it kind of relates to a question you asked earlier. It was a naysayer physician about us doing EMGs. And it was really interesting because the physician said, I want to send you to get an EMG by a real doctor. It kind of just relates to everything you're seeing. And I was like, wow, okay, that's one way to go. So she went and had the EMG by one of the other places after
by a real doctor, right?
a real doctor. And it took, let's say, a better part of 6 to 8 weeks to go through this process, right? The patient then brought that EMG report back to the naysayer physician. and asked a physician to interpret the report. How does this impact my care? And she's like, oh, I don't understand this. I don't know. I can't read this report. So here we are. She wasted 8 weeks and she's like, well, I'm going to go to someone who does. And so then she paid cash for me to redo the EMG because now she used her benefit. I did the EMG and we went through what I believe was a thorough lower body EMG, trying to rule out neuropathy or radiculopathy. If memory serves me correct, I found a little bit of neuropathy, not much, not something that I was going to, be overly concerned about, especially considering her age. And at the end of that hour, she said one of the most amazing things. She goes, that was the most powerful healthcare hour I've ever had. Not only did you do the exam, you helped me explain the exam. And then I always say I like to give some golden nuggets. That's my thing because I'm a therapist in training. We just care about helping people. And so at the end of the EMG, I always give 1, 2, or 3 things I want them to work on before they go see their clinician back on the floor. And that way they can give feedback. Did it help, hurt, or hinder? She still sticks out in my mind. And that was huge because now we have a huge believer and we were able to impact her care, basically calm her nerves down. She did not have a major radiculopathy and we just were dealing with mild neuropathy symptoms. And she was very motivated to do whatever we asked at that point. And that was a vivid case more recently that kind of hit a lot of those different buckets.
I want to address something that many times becomes a hindering factor for therapists to get on a patient to do, let's say, an EMG study. And it is this viewpoint. We're going to do an initial evaluation on the patient. We're going to start treatments on the patient. If the treatments we give, they are not effective in 4, 5, 6 weeks, then we're going to refer the patient for an EMG test and see what happens. And this essentially feeds the whole failed PT principle because obviously if the patient got better, you won't do anything else, but you go through the process to prove that the patient did not get better, and therefore what you did for them with PT, it failed to get the patient better, only for you now to do the testing to identify what would have been the proper patient management that you should have done on day one. In the paradigm to physical therapy treatment, you do the PT eval, the treatment plan, the treatment intervention, re-eval, and you adjust the treatment of care and continue PT, and you're ending care or you go to a wellness program. But essentially, the answer here is for the specific subset of patients who are medically qualified for the diagnostic testing, to do the diagnostic testing right at the beginning of the care and to utilize the results of the diagnostic testing, even if you are a PT who is not trained in diagnostic testing, to utilize the results of diagnostic testing in the formation of a more appropriate treatment plan. This happens for a simple reason, that if we look either at the physical therapy environment or at the medical office environment, for a physical examination that either a physician does or a physical therapist does, that physical examination will have a certain degree of sensitivity and specificity for the specific patient condition. So the fact that EMGs exists, MSK ultrasounds exist, and MRIs or any other diagnostic test exist, those are tools that you use them to help you improve the sensitivities and specificities of your physical examination so that you can derive to more appropriate patient treatment plans. And actually, the notion that such treatment plans can be more appropriate is not new. There are several studies that demonstrate that treatment plans can improve significantly. This is the study that we published in 2020 that demonstrated that in 61% of the cases, the patient management changed. And also, prior to that, in 2018, there was a study by Lindstrom that showed, not in physical therapy practices, but in general primary care practices, the patient management did also change because of the results of EMG testing.
I feel like for me, being a clinician, plus or minus of 20 years when I started learning about this, I was probably the most difficult person to change that practice pattern for. I've been doing this for 20 years. I know the answers to the exam. You have all this clinical intuition because you've done it. What's amazing is my younger therapists, the younger generation, anywhere from 0 to 5 years of clinical experience, they seem to embrace this knowledge much better. I feel like it's us old dogs that have had a difficult time. And maybe it's a little bit of pride for me that's not wanted to change that. I know the answer. I don't need help, right? I can do it on my own. And I think for me, that's probably a personal issue more than most. But now here we are fully integrated in a diagnostic form that we have our patients fill out. Are you having any numbness or tingling and any of these symptoms? What it really did is it kind of removed some of me out of the equation. And this is what the patient's reporting. And so if I see check marks in any of those areas relevant to testing, I'm going to send that patient more than likely to a diagnostic exam, to the point now where all of our forms, if they check that mark, the therapist will, if they agree that it's needed, that we added a little section, what they think might be going on. And then we send that to the physician for signature, and we'll usually get them in for an MSK or an EMG within a week or two, depending on insurances and all that kind of stuff. If it's cash pay, much quicker. It is now our standard of practice. And in fact, I think we even have our patients asking for us, do I qualify for this exam? And I think what's amazing is how it has helped us treat more confidently. And I think our patient education piece is so much better. And I think the reality is, as therapists, as much as we might like our fancy exercises and our fancy mobs, our most valuable asset is our brain and our education of our patient. We're changing habits. And if we know what we need to change, it's amazing the impact we can have. And that's probably been the most fun. I mean, I'm not having to do a bunch of fancy techniques. It's really coaching them to be successful faster with our hardcore data to do it. And so we've changed our paradigm. It wasn't easy. I've been doing this for 6 or 7 years now, and it's taken us some time to fully integrate it. But now I can successfully say it's fully integrated, at least in our clinical practice.
And actually, we also have Ryan Hamilton. He just recently got his ECS, and congratulations, Ryan. Very well done.
Was nerve-wracking, but I was glad to get through it, and I felt well prepared for the exam, and it was just a huge relief to get it taken care of and get it completed, and to be able to start seeing Medicare patients. It's really opened up our practice in my clinic significantly, because my volumes has greatly improved since being certified.
So Ryan and Skye, let's address kind of specifically, what are the challenges between the interactions of people who are trained, diagnostics specifically, and people who are not trained on how to do the testing? What are the challenges on the interactions there, and what do you believe can be done to strengthen those relationships and create much easier patient flows through PT diagnostics back to PT?
In the beginning, I didn't know, and the team didn't know what this thing was, right? And the value of it. And I think what happens as you dive into it, and as Ryan said, as you get into that ECS and studying, your world becomes this ECS, and everyone else is continuing to take care of patients. And so you create this dichotomy, if you will, where one person's focusing on this and the other's focusing on this. But I think one of the most successful actions, and we meet every week as a clinical team for an hour, and we've made twice a month, like the last 5 to 10 minutes of that meeting, just where the diagnosticians are sharing some of the wins that they had from their diagnostic testing since the last time. So it's real and relevant. And I think that's probably created more of a collegial approach, because it allows the clinician who understands the test to kind of explain what it is. And then the clinician that doesn't have that background to ask the questions in a safe environment so no one feels dumb, and we can really just solve the problem. And I think what's really cool for us is we're just trying to start understanding neuro MSK and EMG. So you do a carpal tunnel exam, and then you throw on that ultrasound, and you're like, hey, there's a space occupying thing there, a cyst or something. Like, that's giving the physician the answers to the test, or for us as clinicians, recognizing, hey, this is something we can or we can't help more readily, or something we need to pay attention to. But I think that weekly or bi-weekly touch point in the clinical meeting has probably been the most valuable, because it's not some PowerPoint presentation. It's like, here's the study. Likely they know the patient. It's just real and authentic. This is how it impacted what I did. And hopefully this is helpful for you guys.
Physicians are used to this paradigm. They will usually see a patient. They will send that patient to do blood work. They'll send that patient to do an X-ray, an MRI, an EMG, or whatever. They will receive those reports, and then they'll bring that patient back and modify their treatment based on those reports. When the patient comes into your office, let's say, and you do not know that they have cholesterol levels at 300 or triglycerides over 1,000 or something. You don't know that. So you need those labs to see that. You have the patient who is complaining for some dizziness. Maybe you need more testing for that to see what causes that dizziness. Maybe their blood pressure was fine, but they needed more testing. Same thing. I believe that the physical therapist has to adopt the approach that they have the power to obtain data points that can help them create more appropriate treatment plans and address their patients' problems more effectively. You know, sometimes I know that people are concerned and they say, hey, you know what, if I send that patient for a test, I will increase the cost of care. Well, really? Is that a true datum? Actually, it is not, because we do have studies that demonstrate that, and again, we don't have studies on the area of diagnostics on that, but we have studies in the area of physical therapy that when physical therapy is being used as the first means of care to a patient, the overall cost per episode of care decreases for a patient. But look, you cannot see what is the cost for physical therapy, what is the cost of surgery, what is the cost of the other procedure, what is the percentage of failed cases. You cannot see them isolated in separate silos. You have to see the total cost of care of a patient. And if you are able early on in the process to get better answers, you're going to be able to decrease that cost of care. If instead of doing a dozen of PT visits, before you do some type of testing, EMG or ultrasound, to realize that that patient was not really a candidate for PT, but they had to have a rotator cuff surgical approach first before they came to PT, you would have saved to the patient aggravation, you would have saved time to the patient and money to the system. Forget about the surgery. You have a patient who comes in, they are complaining for numbness and tingling in their first, second, and third digit. Your phalanx and tenelles, they are positive. And because their phalanx and tenelles were positive, you start treating that patient for a carpal tunnel syndrome. You check the neck, range of motion is normal. You do a quadrant test, you do a Sperling's test, and it is normal. Of course it's normal. It has 30% sensitivity. It will be abnormal in only 30% of the cases. And only to see that this patient is improving marginally and they still have numbness, tingling, and pain, and now it starts extending above that wrist. Only to send that patient back to the physician because we did not approach the problem, or send that patient after 4 weeks of PT for an EMG only to find that there is C6 radiculopathy. The argument is, but yes, I will see the muscle weakness in a case of a cervical radiculopathy. No, you will not see the muscle weakness, because muscle weakness to establish, really, to get that 4 out of 5 in manual muscle test, you really need to lose a ton of motor units. But the moment we go with a needle, we go with a pin inside that muscle, even at the very, very beginning, when you have, 3%, 4% of those motor units lost, we're going to be able to identify it. And you're going to save that patient right early on, not after they lose power, not after they lose strength. So the early use of diagnostics on the patients is a very important thing. So what is the idea here? The idea is, number one, to identify which patient needs to receive these diagnostics. The way you identify it is through the use of the screening tool. You use the screening tool for you to get the medical qualification of which patient is an appropriate candidate for EMG testing or MSK ultrasound testing. Then safely you refer that patient, you get the results back, and you use those results to create a more appropriate treatment plan for your patient. That's how it works.
One thing that helps me is picturing everyone as a family member and really trying to provide the best information to that person. I guess assuming you love your family members and you want to take good care of them. But the reality is that's something that's helped me, is like, I need the answer to this so I know which path to take with you. And honestly, sometimes it's not that physical therapy is going to be the best answer. Sometimes, I'm going to refer you out. And I think as we try to start seeing ourselves as that primary care person, we have to be a lot more comfortable referring these services, both internally and externally, and getting ourselves out of the mindset of an end user. And that's been freeing of my mind. It's really allowed me to be a part of the larger medical team and hopefully get the answers to the questions that the patient really needs.
I agree with you. I want to surprise Skye a little bit by showing something here for which I'm very proud of.
And now, the moment you've all been waiting for. Introducing our 2 Practice of the Year award winners for 2023.
We currently offer musculoskeletal ultrasound and also EMG and nerve conduction studies.
For us, it's a differentiating factor for a couple reasons. Being able to get to the answers quicker, being able to help patients solve the problem that relates to their situation faster. Hi, my name's Skye. I am the owner here at NCEPT Physical Therapy and NCEPT Diagnostics.
Hi, my name is Christy, and I'm the Administrative Director here at NCEPT Physical Therapy.
My name is Dr. Tony Sear, physical therapist, co-owner with my wife, Melissa Sear.
I'm Dr. Melissa Sear, and my husband and I are the co-owners of Kinetics Physical Therapy. At Kinetics, we offer musculoskeletal ultrasound. We also offer electromyography, the EMG, and we also perform nerve conduction studies as well for our patients.
NCEPT offers EMG and nerve conduction studies as well as musculoskeletal ultrasound. You gotta increase your value. There's lots of competition here. If you want to be different and differentiate yourself, this is one of the tools that we found very effective to do that, to the point where it's allowed us to negotiate contracts that they wouldn't allow us to negotiate before. It's helping the patient, helping the clinician get the answers faster, and helpful for the staff to be able to provide an opportunity for them to make a living here in Southern California.
Having the additional diagnostic testing, the ultrasound, the EMG, and nerve conduction study, we're able to more specifically, pinpoint what's going on, and it helps us to be more of that primary care point of entry into the medical system in the Gainesville area.
I mean, that's why we do this. When I get a patient here, I have all my PT tests and physical examination that I can do. What I think the value that we bring here at NCEPT, having both the musculoskeletal ultrasound and the nerve testing, is that we get to be that much more specific. This testing lets me know what exactly is going on. Rather than with my physical examination, I get to give them educated assessments. But with this testing, I really get to be specific of this nerve is damaged here with this kind of damage, or it's not. And then this is the next steps we need to take.
Over the years, we've seen lower and lower reimbursements. We've constantly looked at, what are ways that we can work on improving our profit margins. There's things that we've done as far as adding cash-based services. And diagnostics was also part of that. Hey, we can get reimbursed at a higher rate with performing these tests, and it helps our patients. It's like a no-brainer. Let's do this.
We have 3 major managed care loops in Southern California, and we're contracted with 2 of them now. The second one wouldn't have happened without the EMG. It was a system I've approached for 15 years, and they kept saying no. And then I started doing some EMGs for a local physician. He was the kicker. Not only did it give us a contract for EMG, it also gave us a PT contract that we had been trying to get for 15 years. So definitely a powerful tool.
We want to be the top of the list that patients choose from whenever they're coming to PT. We don't want them to settle for coming to Kinetics for PT. We want them to seek us out. And providing the diagnostic testing, that allows us to have an extra bump over the other providers they could choose from in town because of the level of care that they're getting here.
Got involved with HODS really because I was looking for an opportunity for my team. Reaching out to Dimi, talking through it, and getting to a point where we can bring this to our patients and our community just made sense, We've spent the last few years trying to make it work, and I'm excited to say that it's working, so that's good.
The folks that are part of HOD, they're wanting to be on that cutting edge, and they've got great ideas. And it's really cool to be able to work with folks who have already gone down that road and tried different things. And hey, this worked, this didn't work, and try this, so that has been huge for us.
These 2 practices are making a positive impact on their communities by providing a quality of care that takes physical therapy to the next level and truly exemplifies what it means to be a HODS-approved diagnostic center. Congratulations to NCEPT and Kinetics Physical Therapy, our 2023 Practice of the Year award winners.
Skye, I just want to say that I'm so proud of you and your practice and what you have created there for your team, for your local community, but also for the impact that you have been create for the physical therapy profession. And I'm so happy to be associated with you. And thank you so much for joining us today and sharing with this awesome group all that you shared.
Thank you, Dimi. I mean, it's been great to be a part of the bigger team, and again, giving us the tools to get it done at a high level. So thank you for that.
Thank you for joining me in today's episode of Your Practice, Your Money, where clinical success meets financial freedom. If you found value in today's episode, please remember to subscribe here or on Apple Podcasts, on Spotify or YouTube. And please leave us a review and share about our podcast to your friends and colleagues, because this can help more practice owners add value to their practices and solve everyday problems. For more strategies, resources, and tools to help you grow both your clinical impact and your financial freedom, head over to www.yourpracticeyourmoney.com. Until next time, keep building the practice and the life you deserve. Take care.